I'm going to get us started here. I want to thank everybody for coming to our webinar today. We've had an amazing turnout of people all across the country, which I think is a testament to Dr. Gearhardt's, the impact of Dr. Gearhardt's work and the growing interest in this particular topic. My name is Dr. Kim Dennis. I'm the Chief Medical Officer and co-founder of SunCloud Health, where we provide residential treatment for patients with complex comorbidity, including eating disorders, addiction, trauma, mood disorders, and anxiety disorders. And I have the pleasure today of introducing you all to a person whose work I've followed really since I started as a clinician, and that is Dr. Ashley Gearhardt. She is going to be speaking with us today on the topic of can food be addictive, the relevance and risks in eating disorder treatment. And I would like to just start with some of the content may be triggering or confusing to people who are accustomed to treating or have restrictive eating disorders. So if anybody is triggered during this webinar, I would like to encourage you to do whatever you need to do to take good care of yourself. Dr. Gearhardt is a professor of psychology in the clinical science area at the University of Michigan. She earned her bachelor's in psychology from the University of Michigan. While working on her doctorate in clinical psychology at Yale, Dr. Gearhardt became interested in the possibility that certain foods may be capable of triggering an addictive process. To explore this further, she developed the Yale Food Addiction Scale to operationalize addictive eating behaviors. It has been cited over 800 times and translated into over 10 foreign languages. Her areas of research also include investigating how food advertising activates reward systems to drive eating behavior, and the development of food preferences and eating patterns in infants. She's published over 100 academic publications, and her research has been featured on media outlets such as ABC News, Good Morning America, The Today Show, The Wall Street Journal, and NPR. And without further ado, I will turn this over to Dr. Gearhardt to share her screen. At the end, after an hour of talk, we'll have 15 minutes for questions and answers, which if you have questions, you could type those into the Q&A box on your webinar screen. And we'll also let you know at the end how to go about getting your CME and CEU certificates.
All right. Hi, everyone. Thank you so much for having me. I'm so honored to be here and thrilled to speak to you all about my research. I just wanted to make sure everyone can hear me okay and see my slides okay. Thumbs up. Okay, fabulous. And just to start, I'm going to be talking about, can food be addictive? Are there certain foods that can trigger addictive-like mechanisms? And, what might this mean in the context of eating disorders? And I do want to just kind of start by really acknowledging upfront that I'm not saying, oh, this is the treatment we should be considering this for everyone with an eating disorder. I'm really a big fan of individualized care and thinking holistically about what a certain person needs. And so please know I'm talking about this in the context of a phenotype where addictive processes may be more relevant and not suggesting this as a blanket approach for everyone. And so I might just start with a disclosure slide. I don't have any conflicts of interest. I receive funding from the National Institute of Health and the American Heart Association. And I like to start my talks a little bit by thinking about how we create addictive substances. Addictive substances are so common in our society, cigarettes, alcohol, but they're not nature-made, they're man-made. What we do as humans is we take something that has a reinforcing ingredient that our brain reacts to and likes, like nicotine. And here what I'm showing you is a tobacco leaf that naturally comes higher in nicotine. But people don't consume tobacco leaves in a sort of pure form. They really consume them in a processed form that's man-made, that we dry and cure tobacco leaves, and that allows us to smoke them as humans. And by smoking dried and cured tobacco leaves, we're able to have a high level of nicotine delivered into the body and into the brain that rapidly spikes the reward and motivation systems and then causes a bit of a rapid crash. And that psychopharmacological profile is really appealing and stimulating and can trigger addictive like responses. But we've had tobacco in this kind of form where it's dried and cured and people could hand roll cigarettes or smoke it through a pipe for a very large part of human history. And it really wasn't until the 1880s when the technology advanced and there were industrialized cigarette rollers, where going from being able to hand roll 1 or 2 cigarettes a minute, people were able, through technology, to have this machine roll thousands of cigarettes every minute. And this allowed for this to become a big business and for people to kind of mass produce cigarettes. And what the big tobacco industry did is they really further ultra processed the cigarettes that we know in our society today. There's over 4,000 chemicals in every cigarette. And so while, yes, they deliver this high dose of nicotine in a rapid way, they're also amplified by things like menthol, sugar, cocoa that really change their flavor profile. They have stabilizers in them that make them cheap and shelf stable. And this allows the industry to mass produce them, heavily market them, and make them highly affordable to people. And when this happened, when our tobacco environment changed so rapidly to have ultra processed cigarettes all over the place, we saw an over 1,000% increase in cigarette smoking in our society. And it was a huge public health crisis that was associated with more lung cancer, emphysema, disease. And even though people wanted to quit and knew these cigarettes were unhealthy, they found that they were just unable to do so because of the addictive nature of these highly reinforcing man-made ultra-processed substances. So taking a step back, what does this have to do with food? Well, our reward and motivation system that tobacco cigarette uses to addict us has really been shaped by our need to get calories. Our reward and motivation systems in the brain really want to make sure we're getting nourished. And so we've faced famine for the majority of human experience. And so reward systems in the brain that are more responsive to high sugar food, high fat foods that give you more calorie bang for your buck, that really is more effective at stimulating the reward system of the brain. But for a long time, these kind of high reward value foods were high sugar foods like fruit or high fat foods like nuts or meats, but they were scarce. And again, kind of technology to the rescue, humans have gotten really good at stripping out these reinforcing ingredients of carbohydrates and fats and refining them into their kind of main, most potent form, and then combining them into thousands upon thousands of unique, ultra-processed, highly processed foods that deliver doses of refined carbohydrates and added fats to the brain at doses that don't exist in natural foods and at rapid rates that don't occur in natural foods. Ultra-processed foods strip out water and fiber and protein and alter the food matrix so you can eat them more rapidly. They melt in your mouth, they get absorbed in your gut more rapidly, and they spike your brain more rapidly. And so as these sorts of highly processed foods, often called ultra processed foods, have come to dominate our foodscape since about the late 1970s and 80s, we've seen this massive uptick of people really struggling with their intake of these sorts of foods and eating in excessive ways, that even if they know they have diabetes or they'd really like to eat these foods in more moderation, they find that they're unable to do so despite trying very hard. And my lab is really interested in whether part of what's going on here is that these ultra-processed, hyper-palatable, intensely rewarding foods have crossed the threshold from food into a substance that can trigger an addiction in some people. And really, the parallels between ultra-processed foods and tobacco don't kind of stop at this kind of philosophical way. We really know that Philip Morris and R.J. Reynolds, the big tobacco companies, started buying up food companies in the late 1970s and 80s. General Mills, Kraft, Hawaiian Punch, and they really transferred their racial ethnic marketing strategies, their children-focused strategies, the flavor additives that they developed for tobacco, and really transferred those into their food portfolios. And my colleague, Tara Fazzino, has done some really interesting work on how tobacco-owned food companies in the 70s and 80s specifically had more hyper-palatable foods, that they developed a more hyper-palatable and reinforcing food system, and that other non-tobacco owned food companies eventually caught up. So tobacco divested of their food port holdings in about the mid-2000s when our concern about obesity and diet-related disease increased, but they really left a huge mark on our current food supply. And this is the paper from Tara where she showed that U.S. tobacco companies selectively disseminated hyperpalatable foods into the U.S. food system. So it's a really good read that shows you some really excellent empirical data on that. And so what does this have to do with eating disorders? I think there's really some fascinating emergence parallels. So we know, the term anorexia was established in the 1800s, in about 1873. Sir William Gall pointed it out that it occurred in both males and females. So it's been around in the medical record for quite a while, but it really wasn't until the late 1970s that we saw cases of bulimia rapidly rising in the US, England, France, and Germany, countries where at the same time ultra-processed foods were becoming more available and accessible and marketed. It wasn't until the 80s that DSM was listed as a separate eating disorder diagnosis. And then we know it was the 90s and 2000s that we started to pay attention to binge eating disorder. And when I look at the kind of parallels in the time frame of when binge type eating disorders marked by kind of a loss of control intake became kind of medically recognized and more prevalent, it really follows the time course of when our environment changed and these sorts of addictive, like ultra-processed foods, became more dominant. And this really shouldn't surprise us when we think about this mechanistically. When we think about addiction, the mechanisms that we know are kind of underpinning addictive disorders are that reward systems start to go awry. People experience intense cravings, especially in responses to emotions or cues. The people who are losing control of their intake of things like alcohol and cigarettes really can struggle with impulsivity, controlling their behavior when they need to stop. That high levels of emotion dysregulation are associated with addictive disorders. And then we have mechanisms like withdrawal and tolerance that people report when they try and cut down on a substance. They experience anxiety and agitation, or tolerance that they need more and more of the substance to get the same reward effects. And a really key function of addiction is that not all substances are capable of triggering this addictive disorder, but that people even who struggle with emotion dysregulation or impulsivity or reward profiles, they don't get addicted to water. But once you have an addictive substance delivered at a high dose rapidly, like you see in alcohol beverages, people can start to develop an addictive response to that. And when we look at our current kind of approaches to understanding what are some of the mechanisms that are underpinning, especially binge type eating disorders, we talk a lot in the field about reward dysfunction, craving, impulsivity, and emotion dysregulation, these kind of core addictive mechanisms. And we also talk about things like restraint, that people are trying to restrain and restrict, and that maybe has a causal mechanism. And also that shape and weight concern cause people to be distressed and then to develop these more restrictive patterns that maybe then lead them to binge. And so when I look at the mechanistic overlap as a scientist between addiction and eating disorders, I see that we're really talking about a lot of similar mechanisms and then some distinct mechanisms as well. And I like to kind of start talks as well when I'm talking to not groups that aren't necessarily addiction scientists, to think about what are some of the myths that people will think about when they think of addiction. And so, oftentimes I'll have people say, well, like, I eat Oreos and I don't feel addicted to them. And that's true. Most people who use an addictive substance, only a subset really develop a clinically significant and impairing addiction. When we look at things like alcohol, the current prevalence rates are that 90% of adults drink alcohol at some point, but about 8 to 15% actually become addicted. We see that cigarettes are actually are arguably our most addictive substance, with about 1 out of 3 regular smokers actually developing an addiction to the cigarette. So not everyone who uses becomes addicted. I often hear people say that, they really think addiction means that you're intoxicated, that your mind altered, that you kind of can't function. But we know cigarettes are addictive, and they're not intoxicating. People can go about their day-to-day life and function while smoking cigarettes. That not all addictions include binging. That we see that things like chain smoking, where people get up and they just kind of repeatedly dose themselves in a regular, systematic way across the day, is a profile we see with addiction. Same thing with drinking, where people wake up and just systematically drink throughout the day but don't go on binges. And we also know that withdrawal is not necessarily addiction. That was a misnomer for a really long time, that we thought it was really about the withdrawal syndrome, that when people cut down, the withdrawal was so aversive that that's what was driving addiction. But we see with tobacco and cocaine, their withdrawal syndromes are really more psychological in nature, of agitation and irritability, and that a lot of people who are addicted never go through withdrawal. And that overall, our understanding of addiction really focuses that it's an interaction between an addictive substance and individual specific risk factors and the environment in which they operate, which may be really promoting the addictive substance, making it accessible, socially acceptable, heavily marketed, and affordable. And when all of these things kind of combine, we end up with addiction epidemics, which are huge public health crises. And so this question would be, like, how would we know if some of these really ultra processed, highly processed foods are really addictive? And we don't have in the field right now any sort of objective biological response that tells us whether something's addictive or not. You can't image the brain and say, oh, we know tobacco is addictive because it did this specific thing in the brain. We haven't reached that with our science. We've really made decisions that things like tobacco are addictive or cocaine's been addictive based on psychological and behavioral responses that people demonstrate. And so I'm going to talk to you now using tobacco as a benchmark, and kind of looking at the 1988 Surgeon General's report, where after decades of debate, we kind of determined that, yes, tobacco products like cigarettes are actually truly addictive. And this isn't just a bad habit, but these are addictive substances that are triggering problematic responses. And so the primary criteria that we use in the context of addictive disorders is whether they trigger compulsive use, an inability to stop despite a desire to do so, and or negative consequences. And I think, when we see this in the context of ultra-processed foods, we see that people are consuming these even if they want to cut down, even if they want to consume them more moderately or reduce their intake in the face of even life-threatening health conditions, that they're struggling to do so. And we really measure this in my lab to try and even get closer to the addictive disorders definitions with the Yale Food Addiction Scale. And what this does is it applies the diagnostic criteria for substance use disorders and applies it to the intake specifically of highly rewarding ultra-processed foods like chocolate and ice cream and pizza and French fries. And what we do is we assess the frequency in which people are experiencing addiction symptoms like loss of control over intake, having intense cravings, inability to cut down despite a desire to do so, having inability to cut down despite having negative consequences in their physical or psychological health, and tolerance and withdrawal. And this scale has 35 different items that assess the frequency of these sorts of behaviors. And it provides a scoring option, which is a symptom count of how many symptoms people are experiencing from 0 to 11, but also a diagnostic threshold that says, do they have 2 or more symptoms plus clinically significant impairment or distress? And that's the diagnostic threshold we use to diagnose alcohol use disorders or tobacco use disorders or cocaine use disorders. Here's a quote from a qualitative study we did in my lab of someone who endured severe food addiction on the Yale Food Addiction Scale. And they said, I can't even be in the same vicinity as Krispy Kreme or any type of donuts because I will just finish a dozen all by myself. And I'm a type 2 diabetic, so that could kill me. And I know that. And I know I shouldn't be eating all of those. I shouldn't be eating one, let alone a whole dozen. But for some reason, I just can't stop eating them. And so to me, this really captures that kind of compulsivity that if we change some of this into, I know I have emphysema and I shouldn't be smoking one cigarette, let alone a whole pack. And I know this could kill me, but I just can't stop, even though I know that I should. We're seeing kind of some of this similar drive and appeal here. When we look at the prevalence based on the Yale Food Addiction Scale for what might we be seeing, we see that in clinical samples of adults who are presenting for treatment based on meta-analyses that about 1 out of every 3 are meeting that food addiction diagnosis. If we look in just a general non-clinical sample of adults, it's about 14%. I think that's numbers important because when we look at something like alcohol, which is a legal, easily accessible, addictive substance, we see a similar prevalence rate. About 14% of adults are meeting for an alcohol use disorder based on these same criteria. I also think if we compare this to the prevalence rates that are currently estimated for eating disorders, it's much higher. So we see that the current estimate for binge eating disorders, probably 2 to 3% of adults, bulimia nervosa, maybe more around 1.5%, anorexia at 1%. And so when we look at this, there's the prevalence of a food addiction phenotype is much higher than what we're seeing with our traditional eating disorder diagnoses. When we look at children, we're seeing that about 1 in 5 children with overweight are meeting this food addiction phenotype. When we look at a non-clinical sample of children based on meta-analyses, it's about 12%. And that's something that if we think from an addiction perspective is really shockingly high. Traditionally, we try and limit children's exposure to or marketing for addictive substances, and we don't really see high rates of addictions in children, but highly ultra-processed foods are now 60 to 70% of the average American child's diet. So when we think about this in the context of overlap with eating disorders, what we see is that, yes, eating disorder samples are more likely to have high food addiction symptoms. You can see this from a paper here that an eating disorder sample relative to healthy controls or a gambling disorder sample are averaging around 8 symptoms of food addiction on the YFAS. And when we look at the prevalence of subjects who meet the food addiction threshold in this eating disorder sample that was collected relative to a healthy control sample collected and a gambling disorder sample that was collected, it's about 80%. So people with eating disorders are meeting this food addiction phenotype. This seems to really vary by the eating disorder diagnosis. So you'll see here that the symptom count for the Yale Food Addiction Scale is highest for bulimia nervosa and binge eating disorders, so the binge type eating disorders. And that when we look at the overall diagnosis in this study, that the vast majority of individuals with bulimia nervosa are reporting this addictive phenotype of 95%. And binge eating disorder, it's down around more 80%. Other papers have found as low as 50% in binge eating disorders. But surprisingly, we're still seeing kind of high levels than we would expect in anorexia. So it's about 70%, which was really surprising to us in this study, given that that's a restrictive type eating disorder. So what might be going on there? And I'll talk about some data on that. But when we look at this is some work done by Carlos Grillo's lab. So I'm showing you that a lot of people who present with binge type eating disorders are endorsing this addictive phenotype. And we actually don't say addiction anywhere on the YFAS when we ask people to fill it out. We just ask about the behaviors. And we don't ask, do you think you're addicted? That we just feel like that's too priming. And we really focus just on the behavioral and psychological indicators of diagnosis. What we're seeing here in Carlos's group is that, they're seeing that the majority of individuals who had binge eating disorder, in this sample, about 61% were meeting for food addiction, but actually that the majority of individuals in their samples who met for food addiction, that the majority didn't meet for binge eating disorder. And so right now we see that with this food addiction phenotype, if it is a real thing, we're not actually capturing the majority of those people if we are relying just on on eating disorder diagnoses, that the majority of them who report clinically significant and impairing addiction to food are not being picked up on our existing diagnostic frameworks. And so are we learning anything? If we look at something like binge eating disorder and we're seeing that there's a group that's endorsing food addiction and a group that's not, what are we learning here? So this is a study where we looked at individuals who had binge eating disorder only, food addiction only, and a group who had both binge eating disorder and food addiction. And what you'll see is that when it comes to kind of measures for body mass index, eating disorder pathology, objective binge eating episodes, subjective binge eating episodes, that overall, we're seeing on many of these pathological measures that the binge eating disorder only group and the food addiction only group are kind of comparable in their clinical severity across BMI and different eating disorder pathologies. But by far so you'll see how similar those are, suggesting they're both kind of hitting a clinical level of impairment. But the most problematic group that's showing the most impairment is the group that's meeting for both binge eating disorder and food addiction. And so what we've seen in our studies is that this combination group of binge eating disorder and food addiction both have higher BMIs, but also more intense cravings, more emotion dysregulation, more eating disorder psychopathology, more frequent binge eating episodes. And so it might tell us, if we're looking at YFAS as an initial screener for somebody coming into treatment, it might tell us this is a more severe phenotype who's going to be maybe in need of additional clinical care intervention. But it's been really unexpected to find that food addiction is being diagnosed with half of individuals with anorexia nervosa. And how I've been kind of thinking about this is that maybe it's something similar to subjective binge eating. So we know that subjective experiences where someone is not consuming a large amount of food in a binge, but eating a small amount, but feeling out of control is something that's endorsed regularly in anorexia nervosa, especially the binge purge subtype. And I'm curious whether there's kind of a subjective food addiction. And so some studies that have been done looked at 77 patients with anorexia nervosa. And overall, compared to bulimia and binge eating disorder, they did see a lower endorsement of 47% overall met the food addiction phenotype, about 4 symptoms on average. It's still higher, really, than I'd anticipate for people who are clearly underweight. But we saw that in this study, it broke down by subtype. So it was 74% of individuals with the anorexia nervosa binge purge subtype met for the food addiction and 26% in the restrictive subtype. And so this, to me, again, suggests a little bit that it could be this subjective sense of feeling addicted, even if people aren't, consuming objectively large amounts of food. And some research that kind of suggests that in this study is that the BITE symptom score, which is a measure of kind of subjective binge eating, was found to mediate the association between YFAS and eating pathology scores in this sample with anorexia. So again, I think we really need to do some more work on what is the YFAS maybe picking up in anorexia nervosa. But it has been found to be cut a slide for time. It has still been found to be clinically meaningful in anorexia nervosa, that individuals who meet for the YFAS criteria do have more severe presentations of overall psychopathology as well as eating disorder psychopathology. And so again, it may be clinically relevant when trying to do some treatment planning around individuals, even with anorexia, even though we're still trying to kind of figure out exactly what that phenotype is there. But I'll often get a lot of questions from people about, is food addiction just dietary restraint? I think from a traditional eating disorder perspective, kind of growing out of an anorexia historical perspective, the idea has really been that, it's dietary restraint and restriction, that people kind of are rigidly adhering to that. And it's really the kind of inability to adhere to that restraint and that restriction that causes the out of control eating. And, in the field generally, I think that we're kind of considering that for some people, that's very clearly true, but maybe there's other subtypes where the restraint or the restriction maybe is a reaction to a strong hedonic drive for these foods. And so they're actually, in general, we've seen in most of our studies that in adults in particular, when we look at food addiction and dietary restraint, they're actually not significantly correlated with one another. So if the dietary restraint was maybe causal, we would expect to see some higher correlations, but usually it doesn't reach significance, or if it does, it's very weak. But most of the research hasn't been longitudinal. So we looked in a study of adolescents where we see a slightly stronger association between food addiction and dietary restraint. And we followed adolescents, all these are adolescents without eating disorders, just to note, but kind of a general adolescent sample. And we followed them across a 2-year pathway to see, does dietary restraint predict more food addiction symptoms over time, as you would expect if that was causal, or does food addiction predict more dietary restraint over time, if you would maybe anticipate that maybe that's more of a reaction than a causal factor, or maybe not really that strongly related at all. So here what we find overall, just as a first step, is over this 2 years of longitudinal research, that food addiction and dietary restraint are pretty stable over time. They kind of have good kind of retest reliability in this sample across the period. But what we see here is that it's really the first pathway, that food addiction predicting increases of dietary restraint over time is what was significant. The pathway number 2, where dietary restraint is our hypothesis that dietary restraint would maybe predict increases in food addiction over time, was not significant. So suggesting that really overall, even these weak associations we sometimes see with food addiction, dietary restraint, it doesn't really appear that the dietary restraint is maybe predicting or preceding food addiction, which suggests it's a less likely causal pathway. So if it isn't dietary restraint that's maybe causing this out of control addictive compulsive behavior, what might it be? And so the mechanisms that we kind of look at a lot in the realm of addiction are things like inhibitory control difficulties. And so this is some research done in a large sample in Canada, where they found that even accounting for age and income, individuals who had issues with urgency, meaning they had a tendency to act kind of impulsively or rashly when their emotions were high, were more likely to have higher food addiction. And also delayed discounting, another measure of inhibitory control difficulties, where people have a tendency to kind of prioritize smaller short-term rewards over larger long-term rewards. And both urgency and delayed discounting are things that we commonly see implicated in addictive disorders, and we also see in many binge-type eating disorders, and it's a core addictive mechanism. We also see that difficulties in reward functioning seem to be associated with food addiction. So this is a sample of adult women, none of whom have eating disorders. And in this study that is a collaboration with Eric Stice, we looked at neural response when people were seeing pictures of a milkshake or a water and actually getting chocolate milkshake or a neutral solution delivered in their mouth during the scanner. And what we found, even accounting for differences in body mass index, that individuals who had more food addiction symptoms had higher activation and reward cue reactivity circuitry that's implicated in addictive disorders. The medial orbital frontal cortex, the amygdala, and the anterior cingulate cortex. And that these neural regions have been implicated in craving, enhanced motivation, and heightened incentive salience, meaning that cues take on the strong kind of incentive appealing flavor for people who have addictive disorders. And then we're seeing these kind of same reward circuitry mechanisms being implicated in individuals who endorse higher symptoms of food addiction. But just to kind of pivot back a little bit, I keep saying food addiction, and we really called it that when we developed the scale in 2008, because what foods might be addictive or capable of triggering addictive disorders was really kind of uninvestigated and unknown at that point. Most of the work had been done, just groundbreaking work by Nicole Avena, who really looked at sugar and its ability in non-human rodent models to be able to trigger addictive mechanisms. And Mark Gold had done some work kind of showing some connections between weight gain and addictive cross transfer, but we really hadn't looked closely. And so again, as I told you in the beginning, we know not all drugs are addictive. It's really drugs that deliver an increased dose of reinforcing agents like nicotine and ethanol, and that they rapidly deliver those into the system. That's really key. If a drug has a slow release, like you see in a nicotine patch, we just don't see that people really get that addicted to it. And that gives a drug a high addictive potential. So again, when we thought about the food supply, we really looked at these sort of highly processed foods with high levels of refined carbohydrates and added fats that have been processed and stripped down. Well, they kind of have this similar profile of increased doses of rewarding ingredients like sugars and fats, and they are rapidly absorbed into our system. So our hypothesis was that these were the sorts of foods that were going to have high addictive potential. And so usually when you fill out the YFAST, we ask people to think about highly processed foods that have high levels of refined carbs and fats, like chocolate and pizza and ice cream. But in this study, we took out our priming instructions, and we didn't have people think about any sort of food. And then we had them do a forced choice task across 35 nutritionally diverse foods. And this allowed us to kind of pit head to head each food to have people, after they fill out the YFAST, identify the foods that were more implicated in that sort of addictive profile for them. And what we found in our research is that the sorts of foods that people reported showing those core diagnostic indicators of addiction with were all highly processed foods: chocolate, ice cream, French fries, pizza, cookies, chips. None of these foods exist in nature. They're all processed, man-made, refined ingredients. They all develop a dose of both high refined carbohydrates and added fats. And people are reporting these are the sorts of foods that they really consume addictively. When we saw what foods were at the very bottom of the list, they're all minimally processed foods. They're foods that exist in nature. They might give you a dose of carbohydrate like an apple or banana, or a dose of fat like salmon, but the people were reporting that they just didn't consume these foods in addictive sort of ways. And this has now been replicated across a number of samples, that it really seems that this addictive phenotype is specific to highly rewarding, highly processed foods, and that people with a food addiction phenotype eat more of these sorts of chocolate and ice cream and cookies and pizza, and they actually they eat less of fruits, vegetables, legumes, lean meats. And so it's not an overall tendency to overeat all foods addictively, but truly those foods that sort of mimic the addictive profile that we see with drugs. And I think this is really interesting if we think about this in the context of eating disorders, because there's this study by Aiton where she went back and looked at all the food records across eating disorders in her lab, and found that 100% of the foods that were consumed in binge eating episodes, regardless of the eating disorder diagnosis, were these sorts of ultra processed foods. That I go back and forth between ultra processed and highly processed foods. I can tell you a little bit more about that if you want to know why. But that these foods that are all kind of engineered and designed to be highly stimulating and highly rewarding beyond what exists in nature. And so this is clearly really relevant when we think it's not all foods that people are binging on and losing control of, but really these sorts of foods that mimic addictive sorts of drugs. And so this is an example from our lab of someone's lived experience where they had food insecurity, very low food insecurity, didn't have enough money to get enough food each month. And they also had severe food addiction. And this person said, I do it all the time. But just an example is I went to the mall, which is 30 or 40 minutes away from my house, just to get a Cinnabon. And I got extra sauce on it. And if I have other foods in the house, I might have some fruits and some veggies in there, but I'll still go out to the store and get the Reese's peanut butter cup and the Doritos and the 2 or 3 pops. So to me, this shows the specificity where it's really not all foods, but really the specific ultra-processed, highly processed, rewarding foods that are triggering this sort of compulsive drive, even when other foods are available. And so this kind of what I kind of summarize from this section is this idea that we know that one of the things that we know addictive drugs do that help us know they're addictive is that they trigger this compulsive drive where, you feel compelled to get the substance, even if you want to stop, even if you know it's not good for you, even if there's other options available to you, that this compulsive drive is so strong. And I think we see this in this food, Yale food addiction phenotype, and specifically with highly processed foods. The second criteria to think about when we're thinking about, well, do these foods really meet the criteria for being addictive, is that with nicotine, we really determined that these foods were psychoactive, that they have, and what we mean by that is transient effects on the mood as mediated by the brain. And this for a long time was a huge debate in the tobacco world. Were they really psychoactive? You weren't intoxicated. And this is a quote from the tobacco literature. These are some tobacco industry paid scientists. And they said, the concept of intoxication, central to the issue of whether or not a drug is addicting, simply does not apply to nicotine. Moreover, smoking nicotine is clearly compatible with performing everyday tasks and is perceived by the smoker as providing psychological benefits. And so we get this a lot in our research, that people are like, it's not intoxicating, it can't be addictive. But we've really been through this before with tobacco, and it delayed us kind of really realizing the addictive nature of it for decades. But when we have people in the lab, this is qualitative work done by my doctoral student, Emma Schistel, who's out in Indiana. And we ask people, why are you eating, these highly processed foods? What's driving it? And it's not really often about calories or caloric need. It's about emotions, and it's about the desire to change one's mood, to have that transient effect on the mood that psychoactive drugs have. So this is a quote for me: the main emotional outcome of the eating is the intense pleasure while it's happening. The emotional thing is big for me. I definitely eat this stuff to feel better. And so, clearly we're seeing some mood altering effects here. And if we actually even look at measures of psychoactivity, of euphoria, that's measured on this Addiction Research Center inventory that was used to prove that no, nicotine is actually a psychoactive. It can alter people's mood. What you see on this a graph I'm showing you here is on that euphoria subscale, that getting 1.5 milligrams of nicotine directly into your veins can activate a euphoria score of about 6 for smokers. Well, using that exact same scale, some scientists affiliated with the USDA did that while giving people white chocolate or milk chocolate, and found that those euphoria scales actually surpass what we see with IV delivered nicotine of 7 and 6.4. And these are just kind of average Americans. So we're seeing that, again, like the ability for these sorts of foods to alter one's mood can really mimic what we see with an addictive substance like cigarettes. And what do we know about how they impact the brain? And my colleague Alex De Felice Antonio is fantastic, and she and Dana Small have really done an amazing job kind of really mapping out how the metabolic signals of things like carbohydrates and fats in the gut go through different neural afferent signals going up from the gut to the brain, and they all converge on striatal dopamine, and that's our kind of reward and motivation system in the brain. And striatal dopamine is one of the things that we see, the ability for addictive drugs is that they all do seem to converge on striatal dopamine through many different mechanisms, and that they lead to this kind of rapid release of striatal dopamine that seems to be key in their ability to trigger addictive responses. And so what I'm showing you here is that, we're seeing that carbohydrates and fats can really lead to striatal dopamine activation, but can it really be in the same magnitude as something like we see with other addictive substances? And so here, this is microdialysis, which is a major way that we measure dopamine release in non-human animals. And what we've seen in studies is that, nicotine and ethanol, known addictive substances, can activate dopamine in this mesolimbic dopamine system about 150 to 200% above baseline. And when we look at that, when it comes to sugar or highly processed foods, these sponsies that are carbs and fat that exist in Italy, and they do the same microdialysis, it's really about the same magnitude of dopamine release in the mesolimbic dopaminergic system, about 150 to 200% above baseline. And so again, this is not as high as cocaine. Cocaine can release like 1,000% of dopamine above baseline. But it really does mimic what we see with things like nicotine and ethanol, that, sucrose and these highly processed foods are kind of triggering dopamine systems in the brain at a very similar magnitude. The next criteria that was used to kind of consider whether something was addictive that I think is also relevant to food is whether they're reinforcing. And this means, will animals or humans kind of work to administer or gain access to that substance? And so one of the ways in nicotine that people would do this is they would have animals kind of have to work to gain access to either nicotine or a stimulant like amphetamines or cocaine. And that animal would have to choose between the nicotine or the cocaine. And they saw that, even about like 20% of the time or so, animals would choose nicotine over cocaine. And that was used in the Surgeon General's report to demonstrate that nicotine could be, compete with other addictive substances to be highly reinforcing. But when we look at this with sweet taste, using that same model of making animals choose between cocaine or a sweet taste, even if it's non-caloric, we find that over 80% of the time, the animal will choose the sweet taste over cocaine. So you can see that in graph B, that's the kind of prevalence ratio that animals will choose the sweet taste over lever C, which is the cocaine. And that happens across different doses of cocaine. If you look at different rats and you kind of phenotype them, the vast majority are SP, sweet preferring rats that preferred over cocaine. Only one rat preferred the cocaine over the sweet taste, and one was kind of in the middle. And so again, when I think back to nicotine, that we said, at 20% of the time it can compete with cocaine, you were really seeing that sweet taste is even kind of blowing cocaine out of the water, which is really striking and suggests, again, we're kind of hardwired for sweet taste and to prefer it. And in kind of sugary foods, kind of high doses of these ultra processed foods, it really can compete. Another proposed criteria for considering whether something's addictive or not, that's been proposed since the Surgeon General's report, is that the substance can trigger strong urges and craving. And what I'm showing you here is that this is recent research done by Hedy Kober, where she developed a neural map of where craving shows up in the brain for people who are experiencing addiction to substances. And in this neural craving signature, it activate systems like the anterior cingulate cortex, the supplementary motor cortex, the prefrontal cortex. And what she found is that actually the neural craving signature is indistinguishable for craving for addictive drugs and craving for these highly processed foods. So cravings and urges for these sorts of foods are activating kind of the same exact neural circuitry in our brain. And when we think about the role of cravings in our clinical outcomes, when it comes to eating outcomes, weight outcomes, same day or long-term outcomes, Hedy is shown in this meta-analysis that that intense cravings for these sorts of foods have a medium effect size in being able to predict negative outcomes. So clearly, this craving for these foods has this important clinical outcome as it's engaging this same neural circuitry as addictive drugs do. So overall, like if we kind of take a step back and say, if we were using the same criteria we used to determine that tobacco cigarettes are addictive, and that 1988 that stood up to decades of scientific evaluation, do they trigger compulsive behavior? Are they psychoactive? Are they highly reinforcing? Do they endure and induce strong urges and cravings that are clinically meaningful? The answer when it comes to highly processed food across the board is yes. And so when I think about using a benchmark we've used previously to resolve a debate about whether nicotine could be addictive, even though it looked so different than other addictive drugs, I would say that we have met that bar when it comes to highly processed foods. And we published a paper where we outline that I reference here. And so what might this mean? I mean, if you take a step back and say, okay, maybe she's right, maybe for a moment you set aside your skepticism of my science and say, if we did say that these highly processed foods do have an addictive potential, what might this mean? And I think, right now when we think of our traditional treatments for eating disorders, we really kind of downplay the role of the food itself and the way the food, many of these highly processed foods that are the dominant binge type foods, have been engineered and designed by a billion-dollar industry to be highly reinforcing. I mean, the industry will say we try and maximize craveability. We try and induce moorishness where people want more and more and more of the same substance and to hit their bliss points. And I think we might be kind of under preparing people for the fact that they're acknowledging a totally different food environment and that it's really hard to eat some of these highly processed foods in moderation for some of us when an industry is designing them to be hard to consume in moderation, because it really helps pad their bottom line if we eat more than is good for our health. I really want to emphasize that the goal of acknowledging that these highly processed foods might have a role and why people are feeling so out of control and feeling so much compulsivity around their food intake is that the goal is not to increase rigid and extreme behaviors. I often try and really emphasize that this isn't your self-worth. And that's what I see so much, that people really feel like whether I'm eating this or not is my self-worth. And that's not what we're saying here. We're saying that it is hard to figure out. Our brain is not set up or evolved to manage the kind of reward value that these foods have, and that it can be hard to manage for some people. And we deal with this a lot in addiction. The idea of an abstinence violation effect, that people would, say, oh my God, I'm never drinking again. And then they'd have these really rigid black and white rules that then if they had a sip of alcohol, they would feel like they'd lose control. And you'd say, what the hell? I'm just going to go on a bender and I'll start over again tomorrow. That abstinence violation effect that's so key in our understanding of eating disorders actually comes from the addiction world. Like we've kind of talked about that and struggled and grappled with that a lot. How do we help people kind of maybe manage or cut down on these highly rewarding substances in ways that aren't stoking extreme black and white thinking that can backfire on them? And so I look to the addiction world, where some of what we've been really thinking about is that it's not so black and white for people, and that foods kind of really seem to potentially vary in individualized ways on having kind of high reward value risk to low reward value risk, and that we can kind of individualize and potentially help people think about contexts that are challenging for them, and that context that's really challenging, where you're really hungry and you've had a really stressful day, that might be a challenging time to try and eat in moderation a high risk, high reward value food, and that might not be a time to try and cope with food. And so these approaches are things that we work with a lot in an empirically supported treatment for addictive substances, is harm reduction approaches, where the focus is maybe not for everyone, that they don't need to necessarily have an abstinence focus, that we help people kind of find ways to develop strategies while acknowledging that alcohol has an addictive potential, to find ways to kind of try and reduce their harm around intake of alcohol or nicotine. And so harm reduction approaches aren't abstinence focused necessarily. It's based on the person's goals. We really focus on individualizing, understanding personal risks, both what substances are maybe most risky for that person. For a lot of people, they can't find a way to drink liquor in a moderate way because liquor is more addictive and hedonically powerful than something like a lower alcohol beer. We kind of acknowledge that, and we know that certain settings are more risky for people. We understand environmental cues and contexts are key in trying to understand where harm is more likely to occur. But we do acknowledge that the substance has an addictive pull, and that there's variability across addictive substances and what their risk is, and help think about this in a contextualized, complex, and individualized way based on people's needs. And so this is something I think could be really interesting, and thinking about if someone is showing up for a kind of food addiction phenotype, how do we manage this without kind of evoking abstinence violation effects, is these harm reduction approaches, which these were developed to help kind of address some of those abstinence violations issues with other addictive substances. So I think I just kind of want to kind of note that I think there is a risk, if these foods do have this addictive potential, of ignoring it. If it's true and it's just kind of inconvenient, that I do worry that we're underplaying the challenges of trying to eat these foods in moderation for some of our patients. And I worry that it increases self-blame potentially. If we say, it's really not about the food, it's just about the way you approach this food, your attitudes, your beliefs, and people are trying so hard to change their attitudes and beliefs when the substance is engineered to make it hard to do that. I've seen a lot of people say, what's wrong with me? Why can't I do this? And so, I do worry that maybe that even could increase stigma, that it's all on the individual, and that we're ignoring the culpability of the food industry and designing, engineering, and heavily marketing these foods from the moment of childhood. childhood to make it hard to have a healthy relationship with their products. So that's why I'd really like to think about complex ways and actually bring science to bear to understand how can we integrate this into treatments for some individuals that might be helpful without unintentionally activating harms. So I want to thank you for chatting with me today. This is my lab, the Food Addiction Science and Treatment Lab at the University of Michigan. Again, acknowledging supporters and funders for my research. And if you have questions or want to look for scales or anything that I talked about today, they're available at my lab website, which is under here. And we have a little simulated fast food restaurant that we look at research on how people eat in high-risk food environments. So I'm happy to take questions, and I really appreciate your time.
Wonderful. Thank you so much,
My pleasure.
Dr. Gearhardt. So I have a couple of questions in the chat. I don't see any in the Q&A, but I think people are just putting them in the webinar chat, which is fine. I will read them from there. So first question is there high co-occurrence between those with food addiction and drug addiction? And then eating disorder also.
Absolutely. So yes, we do see that. We published a paper last year finding the risk ratios for people who have this highly processed food addiction phenotype with high risk alcohol and vaping and nicotine use, that they're sometimes 3 to 4 times more likely to have co-occurrence between substance use disorders for individuals who have highly processed food addiction. We also see that sometimes they won't also co-occur. Mark Gold's done some really interesting research on this, but there can be kind of cross-transfer addiction where people who are getting treatments for addictive disorders, that when they aren't able to use the substance of cocaine or nicotine, that they actually transfer and start to develop kind of specifically for high refined carbohydrate foods, intense cravings and out of control, and sort of transfer the addictive phenotype from their addictive drug to these specifically the highly processed foods. We also see that people getting gastric bypass surgery, there's some evidence that individuals who have high YFAST scores before gastric bypass surgery are more prone to then go on to develop substance use disorders after they have the gastric bypass surgery and are able to consume foods in the same way. So we do see some of that. We also see a family history of addiction is a predictor of highly processed food addiction. If we think about that in the context of eating disorders, we do see specifically for the binge type eating disorders, particularly bulimia nervosa, but even binge purge anorexia nervosa, high comorbidities with substance use disorders. Anorexia nervosa restricting type seems to have a lower co-occurrence with substance use disorders. I think because they might be engaging really different mechanisms. There's kind of a hyper control versus a hypo control there. So we do see that with eating disorders, that there is this high co-occurrence. And I think it's undertreated as well in the addiction community, that we're not screening or looking for eating disorders and our addiction treatments as much as we should. And we've kept kind of separate. So yes, the co-occurrence does appear to be there.
Awesome. Yeah, and I would say conversely, in the eating disorder field, we oftentimes don't screen as stringently for substance use disorders as we need to be as well.
Yeah.
But definitely in our residential unit that's specifically for people with eating disorders and substance use disorders only, we do tend to find higher rates of people describing the addictive sort of patterns playing out with food that you described.
Totally. I think that's so important. I'm excited about the crosstalk between more of our the eating disorder and addiction groups have I feel like been siloed and excluded from psychopathology more broadly, even though I think as a field we're realizing that there's so many shared mechanisms and we should really be talking together and looking for kind of shared common mechanisms that we can target effectively together. So I'm so thrilled to talk to groups that are really thinking in this in a complex transdiagnostic way.
Right. All right, so next question. You didn't talk about highly processed drinks, soda, fruit punch, etc. Do these operate the same way as highly processed foods?
Yes, that's a good question. So actually, in that study I showed you about like where we got like the foods that were rated as most addictive versus least addictive, we had soda in there. And it was in kind of the second quadrant of risk. And so when I first started doing this work, I actually thought that the beverages would be a lot higher because it's just, mainline sugar right into the system. And we aren't really that developed. Our brain is not that developed to assess liquid calories. Like in nature, you kind of get calories through liquid when you're a baby through breast milk. But even our ability to drink cow's milk is actually pretty recent. So there's evidence that our body doesn't kind of register calories from liquid as effectively. The kind of thirst and hunger systems are separate. And when you get full, when you get satiated, the hunger and reward hormones are super interconnected with one another. So when you're really hungry, those gut peptides that tell you you're hungry, they potentiate reward systems and make them more reactive. And they make them more reactive, whether it's a highly processed food or an addictive drug. I mean, when you're hungry, cigarettes are more reinforcing. And so I thought, oh, these liquid calories, mainline sugar, it's going to be the most addictive food. They are rated as consumed addictively, but under foods that have both high levels of refined carbohydrates and added fats. And I think that's really important because, again, I know I go to nature a lot in evolution. Our natural foods that our brain evolutionarily evolved to handle do not come high in both a high ratio of carbohydrate and fat. If you think we have fruits that are high in carbohydrate, low in fat. We have things like nuts and meats that are high in fat, but lower in carbohydrate. And so when I showed you that work by Alex and Dana, where they mapped the different mechanisms from gut to brain, that fat and carbohydrate seem to have different highways up to the striatal dopamine center in the brain. And for most of human history, we either got carbohydrate or we were kind of getting fat, and we weren't kind of getting both mechanisms activated rapidly at the same time. And so with these highly processed foods, I think when you get the double activation of both carbohydrate and fats, like you would get in ice cream or potato chips, that seems, Alex has done work that it has a super additive effect on the reward centers of the brain when you have the combination of carbohydrate and fat than if you have a high carb food like a soda or a juice on its own or a high fat food on its own. Overall, in general, in my lab, like we see that the refined carbohydrates are the most important, that like people will eat refined, they want the combo is often the most triggering, but people will eat refined carbohydrates in an addictive way on their own, like white bread or a really sugary cereal that people eat straight from the box or soda. We see a much lower rating of addictive risk for foods that are kind of just fat that don't also have a carbohydrate. Kind of like if people report, kind of some bacon or some cheese, a little bit they'll overeat, but often people are naturally combining that with a refined carbohydrate. They're getting their toast, with their bacon. So I really, when I think about what is the most concerning for me, if I had to say a substance that I think is the most key addictive agent, it's rapidly absorbed refined carbohydrates, but that the fat really amplifies the reward power of the rapidly absorbed refined carbohydrate.
Right. Another question, when do you think this will show up in DSM or ICD?
Yeah. So I know there was a recent application to ICD I wasn't involved in that got rejected. I'm currently working on one for the DSM. So it's good news and bad news. The good news is we have so much research out there. I mean, we have over 400 studies in this area applying the diagnostic criteria for substance use disorders to highly processed foods. We have meta-analyses of over 200 studies around the globe. We have met, I would say, the scientific bar for this to be included, at least as a diagnosis in need of future study in the DSM. We have more science than when things like internet gaming disorder were added to the DSM. Sorry, I have to call. I think it has taken me much longer than I anticipated to collate those hundreds of studies into the format that the DSM wants. I am 2/3 of the way done with the initial draft of the application. It has taken me longer than I hoped, but I am plugging away at it and pulling in other scientists to help me. I'm very motivated to try and get this out in the next year to be applied to the DSM, but I am cautious about it because I think if an application goes in that isn't extremely scientifically rigorous, or I think they would like to reject it. I feel like for the DSM, it's going to be a firestorm of, is everything an addiction? So I am really trying to do this as high quality and scientifically rigorous as humanly possible, because I don't want to set the field back by another decade. But I think this is really essential because people aren't getting care. Like, as I said, most people who meet this why fast food addiction phenotype, which is associated with lower quality of life across every domain, they're not getting caught in our treatment modalities. They aren't getting insurance reimbursement. We're not testing treatments like harm reduction or 12-step models to see how effective they are and for whom, because we aren't recognizing it. And it's preventing people from getting the care they need, or even acknowledging that this might be really happening for them. So it's really meaningful for me. And I am plugging along at it, but it's so much work. It's not part of my job description at all. So I'm totally just doing it whenever I can find the time.
Passion project.
Yeah, it is a passion project for sure.
Okay. As a clinician who treats, I'm a certified eating disorder specialist. I'm addiction medicine boarded, particularly for those patients, with multimorbidity, right? Yes. Including medical morbidity, including classic DSM, full diagnostic eating disorder, and, a substance use disorder, and this layer of addictive, compulsive, loss of control eating. How do we go about even talking about this phenotype in a patient population that has been harmed and that can be worsened by what might be interpreted as, supporting diet culture or supporting fat phobia or weight stigma, right?
Absolutely. So yeah, how I talk with this, and I have science to talk to this a little bit. One of my big fears when I started to do this research was that we were going to be unintentionally increasing stigma against individuals who are already being stigmatized for being in larger bodies. And so Rebecca Poole, who's a huge weight stigma researcher, did a study I was not involved with at all, where she did different narratives and told people either, it's our traditional narrative. Oh, people overeat. It's a matter of personal responsibility, just calories in, calories out. And then that's what our society currently tells us. And then she had an addiction narrative, which is, these highly processed foods are designed to be addictive. They're designed to be hard to eat in moderation. People are struggling to find a way to consume them healthily, much like we previously saw with cigarettes. And she found that the addiction framework actually reduced stigma towards individuals in larger bodies. And also I believe she found in that study also reduced internalized weight stigma. I might not feel completely confident about that. Other studies that we've done as well have found similar results, and others have found that this addiction framework doesn't seem to induce people to have more stigma. It actually kind of gives people compassion about the fact that we're being manipulated by these big industries to make their profits higher at the expense of our health. So I think that it can be really helpful, especially when we focus on the industry. It's kind of we did this with cigarettes, that focusing on how the industry was designing cigarettes and targeting kids and engineering them to be addictive, but then not telling people, hiding that they were addictive, wasn't okay. And that we needed to help people who were then struggling with that. I think talking to people about that, certain foods are engineered and designed in these ways very intentionally. And I always preach, it's really important to have compassion for the fact that your brain's doing what it's evolutionarily designed to do. but that the technology and the know-how around engineering these highly processed foods just so outmatches what our brain, and our brain never evolved to handle that. And that I feel like if we don't, as scientists, step in and say, how do we navigate and modulate and moderate ourselves in a food environment that is set up to get us to eat as much highly processed food as humanly possible for gain? If we don't come in and say, okay, yeah, we don't want you to go on extreme diets or fast or try and take this weight loss tea. If you are interested and want to alter your eating, the things I always say to people is we want you to nourish your body with 3 meals, 1 or 2 snacks a day, eat regularly of foods that are nourishing and enjoyable for you, but pay attention to the quality of the food. Try and eat foods overall that are mostly minimally processed foods where you can understand, I always say, like, when I look at a food and I don't understand half the ingredients in the ingredient list and I'm a food scientist, I don't trust that food. And so, and I say, like, the goal is not perfection. It's not, this isn't your self-worth. This isn't black and white, but we want to make the majority of what you're eating every day nourishing real food that our body evolved to handle. And then we want to kind of think about if there are times or places that you're, want to eat or want some of these other highly processed foods, that we really think about you're not doing that as your main way of coping with emotions. So I think it's important to kind of get people nourished, and then these transdiagnostic mechanisms of emotion regulation, cue triggered craving. How do you regulate emotions? How do you take care of yourself? We see strong associations with trauma. We just saw a study, 8-fold higher risk of having childhood trauma for individuals who are showing up with food addiction phenotypes. We want to, whether it's alcohol or cigarettes or food or cocaine, we don't want you to be coping with life with a substance. How do we help you regulate and take care of yourself? And know that, how do you cope with stress, that when you are cued, when you are triggered, when you are stressed, we need to give you tools to help deal with that craving and that strong cue triggered motivational drive that's kind of been wired in, whether it's alcohol or cigarettes. So that's how I really think about it. And I actually think for our individuals going through treatment for alcohol and cigarettes, making sure they're nourished from their diet. We know that if you're hungry and your brain is saying, I'm not nourished, that the reward system of the brain is hyperactive and it's more reactive to addictive drug cues too. So I think we could really integrate having more nourishing, nutrition and helping people feel really with the food is medicine sort of idea, and bringing that into our addiction treatments, even for people who don't have eating disorders, would be great.
Oh. Well, I think, the false negative rate on the Y-fast for people with underweight people with anorexia, even people with atypical anorexia in larger bodies who meet full diagnostic criteria for anorexia, I think that changes. My suspicion, and I don't know if the study has been done, is once those folks are renourished, that their Y-fast scores likely come down, and that that false positive rate sort of disappears.
Yeah, we are finding that in our lab, that when we give people, we've been actually working with our metabolic kitchen to give people keeping them weight stable, like saying this is not a diet. I think oftentimes when people try and eat higher quality food, they then also start calorically depriving themselves. And so oftentimes I feel like, okay, like let's kind of let your brain readjust to food that is not hyper stimulating your reward systems. Like, we do see that people going through a withdrawal syndrome, and that the first couple weeks they're preoccupied and they have craving and anxiety and agitation, and until they kind of re-regulate and get used to real food. And so I think that can be a little bit of a period, but once their brain adapts, I think that can be powerful to think about.
Right. Question about health inequities and disparities that we see both with medical conditions, prevalence rates and outcomes. Type 2 diabetes is an example. When we look specifically at Brown, Black, Native American people, is there data looking at food addiction rates in those folks? And then we know that the eating disorder research is predominantly focused on white populations and restrictive phenotypes. So how does this question of health inequities, where does food addiction fit with that?
We've really been looking at this in the context of food insecurity. So we published a paper. We actually have like 2 or 3 more in the pipeline with one of my doctoral students, Lindsay Parnarowskis, has really taken the lead on this. And she's done qualitative work, quantitative work. We've collaborated with people all over the US. We're seeing that people who have food insecurity are really at heightened risk for food addiction, for this highly processed food addiction. Sometimes up to, our current estimates are anywhere from 50 to 80% at higher risk than those who are not food insecure. And we know that individuals from stigmatized minority populations are more likely to be food insecure due to many of the structural obstacles in our society. And when we looked at this mechanistically, to me, it's really a social justice issue. It's why I've had people be like, oh, well, we all have to eat, so this can't be addictive. I'm like, no, we all have to eat. So it's a huge concern that, like, for the
who has
American,
access to what types of
to
foods
engage with an environment where the majority of calories are highly processed. And if you're poor, it's even more. That's almost the only thing you have convenient, affordable access to. And so from a social justice perspective, I think this is huge, especially we have so many people in my lab who had food insecurity as a child and then are now food secure, but the experience of having food insecurity, a critical time in development, not only increased their risk factor for highly processed food addiction, but also other substance addictions. These are things that we can address in policy ways to, again, have this trans-diagnostic benefit to address some inequities by making sure that everybody can have affordable, convenient access to nourishing food. But if we say, oh, there is no difference between an apple and, apple pie, hot apple pie from McDonald's, they're all food, there's no difference between them. I do see that as an obstacle between us being able to address some of these health nutrition equity issues.
Thank you. So another question, any suggestions for papers or resources on implementing harm reduction, particularly with these ultra-processed food addiction phenotypes?
Yeah, we hopefully coming out in May. So right now there hasn't been much research. We created a manual. We've done a very initial pilot feasibility with some colleagues at Wake Forest. We just got invited to write a paper on it. So in May 2024, we should have a harm reduction paper that both outlines the theory and the feasibility and acceptability of this approach. I always feel like bad when I talk to people who are on the front lines and doing treatment and who see this perspective and want more tools, because we've been arguing over whether it's a real thing for 20 years. And we have only now started to be like, okay, it's probably a thing, maybe. So maybe we should figure out how to treat it. And so I really value the work that people are doing on the front lines, because scientists have not given you many tools yet to say, oh, this works more for this person, or this approach works here. And I feel like we have so much to learn from the clinicians and the frontline workers about what they're seeing when we're in the lab.
Yeah. No, along those lines, what are your suggestions taking this research to improve patient care for providers who treat specifically binge purge types of eating disorders?
Yeah, so specifically for binge purge subtype, again, I think we can all agree that, like, no one's worried when somebody comes into their lab and they have, or their clinic, and they've got their food diary. We're like, okay, nice balanced breakfast, some eggs and, like some fruit and maybe some yogurt. Like, I think we can all agree, regardless of whether you take an addiction perspective or not, that I think normalizing eating patterns so we don't have these huge periods of fasting, and trying to get as much of that to be nourishing food as possible is great. I do think for that binge purge subtype, it is, I think focusing on cravings, that cravings are really strong and intense, dealing with emotion dysregulation, dealing with strategies to deal with cravings, dealing with those sorts of factors. And I think we need science on this, but I think right now I'm really curious if so often we just did a survey and U of M undergraduate sample. Over 90% of people think these highly processed foods are addictive, and our incoming cohort of, psych students at U of M. So I would be stunned. We really haven't done the research that if somebody with binge purge subtype, that if you were like, maybe you're having an addictive response to these highly processed foods, that they would be like, what? I'm shocked. I don't know what you're talking about. I feel like a lot of our eating disorder patients actually believe this already, and that oftentimes they'll tell that to their provider, and then their provider will say, no, there's no addiction here, which can be invalidating. So I think talking to people about, starting with where they are as well and how they make sense of it, and asking them, I think, even about, there's this debate about whether there's maybe an addiction to these foods going on here. The science is still evolving, but what do you think about that? Does that feel relevant to you or not? And then validating their experience and then integrating that into their care in a way that makes sense to them. But oftentimes for me, it can be a entry point into some compassion around how hard it is to consume some of these foods in moderation because of the way they're designed.
Are you talking about person-centered care?
Yes, I am talking about person-centered care. Like,
what is this?
Whether it's an addiction perspective or an eating disorder, anything that says one size fits for all people and at all stages, I just honestly stop listening, because I'm like, we just know humans are too complex for that. I don't think my approaches fit everybody at all, but I think we can, screen and personalize care more effectively and validate our patients and how they're making sense of their experiences.
Right. And I think, while we do have, we have some theoretical evidence base, to at least do screening, right?
Yeah.
So
absolutely.
We have the EDEQ, we have the EDI. Those can help us screen for dietary restraint and deprivation sorts of phenotypes. We have the YFAS. We have trauma scales.
Yeah.
Right. We have the PHQ-9. And I think, using those in addition, we don't have a PET scanner for every patient where we could say, okay, you have an eating disorder, maybe a food addiction. Let's see if it's really your addiction circuitry that's like fired up more, or your, the OCD sort of circuitry that's more associated with anorexia. We don't have that. And I don't think we'll ever have that wide scale.
I don't think so. And even the scientists who do have the PET scanners, we haven't been able to diagnose through brain scans yet. It really is, what people are saying are in their behaviors and their psychology. And I think sometimes we've gotten really excited about our tools with like neuroimaging and genes, and we kind of overprivilege that evidence relative. I found, to me, some of the most compelling evidence, so I make sure I put it in, is the lived experience and the qualitative studies we do with people in our lab has honestly been what has been most compelling to me, over like, oh, look, there's a little bit of this brain region that lit up.
Yeah. All right. I know there's one last question, and then I think we need to wrap up because we're a little bit over time, but I could stay on and talk many more minutes. Last question. I think it's a good one to close with. How do you reconcile this with intuitive eating and all foods fit ideas?
Yes. So that's a good question, and one I think about a lot, and we're doing some science on right now. Someone asked about PCOS, and I know we won't have time to get to it. Oh, shoot. Can I send it to you? I'll send it to everybody. And a study just came out. So I'll just put the link in the chat. And the association is shockingly strong and very concerning. So I want to make sure that gets out there because it's new. That's the first study on it. The intuitive eating, there's a lot I like about intuitive eating, and that it really has people, it wants people to kind of get back to eating to nourish themselves and not necessarily eating for emotional reasons. That I think, diet culture has so much generally been like, the number on the scale is your self-worth, or this amount of calories is your self-worth. And I think we want to bust out of that. Where I have a lot of concerns about the intuitive eating model is this idea that all foods fit. That I think in some ways that simplifies the fact that the foods that people struggle to give themselves unconditional permission to eat are designed to make it hard to listen to your hunger and satiety signals with those sorts of foods. This is for many reasons. Those ultra processed, highly rewarding foods, they slam on the gas of your reward system so strongly that the craving and the desire can take over, and it drowns out those subtle signals of satiety. We see that people really have a hard time in our lab parsing out between homeostatic hunger, where you really need calories, and when you're hedonically craving something. That can feel, oh, it's like, I want this food, I must be hungry. The wanting can actually be because of the cues and the reward and the craving, not because you're actually homeostatically in need and hungry. So I think sometimes if we tell people just listen to your hunger and your satiety cues, we're setting them up to fail. And then Kevin Hall did this beautiful study matching ultra processed foods to minimally processed foods, and food environments where people were in both these environments. So it's the same person in the ultra processed food environment versus the minimally processed food environment. Ultra processed food environments, people passively ate 500 more calories a day. Their satiety signals weren't triggered. The satiety hormones and hunger hormones in their gut started to get dysregulated after 2 weeks on ultra processed food. And so I think we need to be like, we do want you to listen to more your hunger and your satiety signals. And that's really hard to do with everything you're trying to eat as donuts and chips and pizza, because those foods are engineered to make it hard to listen to your hunger and satiety signals in effective ways. And so I want to integrate that we need to kind of think I'm concerned sometimes when intuitive eating is the only approach that it's okay, that is used for people. And it's the idea that it works for all people, no matter what, that we are minimizing the challenges and the difficulties, especially for people who maybe had food insecurity in childhood, or who have really high reward responses to these foods and sensitized dopamine systems. I think we're maybe setting them up with a task that they're destined to fail at, and then blaming them because they're not just being intuitive enough. Right. So I have there's a lot I like about it, but I think there's a lot of context I'd like to be integrated into it as well. And I think we need more science on how it links the two perspectives.
Right. There was one other request for the Rebecca Puel
yes.
citation. So
I was trying to Google it. If I don't know if you have a list for the people who attended.
Yeah, we can send that out.
Okay, great. I will. I tried to Google it quickly, but she has a number of them on it. I couldn't find the one I was specifically talking about, but I can send it to you, Kim, and then have it be sent out.
Wonderful. Well, thank you so much.
My pleasure.
For coming today. Thank you, everybody who came to listen to this talk, and for the great questions that the talk has stimulated as well. And for those of you who want ongoing access to this talk, the recorded version will be available on our website under the list of resources and educational resources. So thank you again, Dr. Gearhardt.
My pleasure. Thank you for having me.
Have a great afternoon, everyone.